Everybody, it is such a pleasure to be here, and I'm really grateful to the BeatSCAD group and FMD group for putting this evening on. You're such a vibrant community. It's an absolute pleasure to be working with you. So we've got a great evening lined up, as already discussed, but we're going to start first off with my colleague, Dr. Aine De Bhailis. So let me introduce Aine. Aine is one of my consultant nephrology colleagues at Salford Royal Hospital. She started out as a clinical fellow doing a part of her MD thesis in fibromuscular dysplasia. So she's going to start us off with a bit of an intro into FMD along with what's new.
Tina, and thanks for that kind introduction. So the first challenge will be to share my slides accordingly. So let me just find that now. Can everyone see my slides?
Yep, they're showing.
Perfect. So we're all here to discuss fibromuscular dysplasia, and for the rest of the talk, I will refer to it as FMD. So a brief outline of my talk. So we're just going to talk briefly about what is FMD, the types of FMD that we see, the symptoms and presentations of FMD, how we diagnose FMD, and also how we manage FMD. And finally, I'll speak just about some of the recent updates in FMD. So first of all, what is FMD? So it's a non-atherosclerotic arterial disease. Excuse me one second. That is characterized by abnormal cellular proliferation and distorted architecture of the arterial wall. So that's the medical definition of FMD, but it is an abnormality of the blood vessels that affects up to about 5% of the US population. These changes causes narrowing and weakness in the vessel walls that can predispose to blockages of the arteries, tears that we refer to as dissections, or the vessels to bulge out or balloon out in manifestations that we call aneurysms. There are two types of FMD. So there's the beaded or the multifocal, and there's focal FMD. And these can affect small or medium-sized vessels. And recently, there's been some changes in the clinical phenotype to also include dissection, aneurysms, and tortuosities of the vessels. So as I mentioned, there are two types of FMD. There's the multifocal FMD, which is the stereotypical string of beads manifestation that's seen on imaging such as angiograms. So here on the left, you see what we call the multifocal FMD, or the stereotypical string of beads, which is dilatations and narrowing of the blood vessels that presents in this way on imaging. So here on the left, you see two images of the renal artery on an angiogram, and you see that stereotypical string of beads, or pearl necklace type manifestation of FMD. On the right, you see the focal FMD, which is a narrowing of the blood vessel. And here you see on the right an angiogram, again of the renal artery, and you see a small little pinch on image A, or a narrowing that we call a stenosis. This type of FMD typically presents in younger women and manifests as ischemia or lack of blood supply to the organ distal to the narrowing. So there's various different manifestations of FMD within the arteries. So the stereotypical ones are the string of beads, or the focal FMD, which involves a specific narrowing of the blood vessel. You need one of these two manifestations for the diagnosis of FMD, but we're also seeing other manifestations of FMD in the arteries that can be found in various other vascular conditions. So we see dissections, which are tears along the vessel wall. We see ectasia, which is a generalized dilatation of the vessel, aneurysms whereby certain parts of the vessel balloon out, and tortuosity, which means that there's bends and twists in the vessel, causing this characteristic S-curve, which we see on angiograms. In the bottom right corner, you see this is an angiogram of your internal carotid artery, which is the main blood vessel supplying your brain. And again, you see this twist and turn in the vessel on the angiogram, which is stereotypical of this S-curve that we refer to on angiograms. So, as I mentioned previously, FMD can manifest in any arterial bed, but the vessels most commonly affected are your renal vessels, your internal carotid, and thereafter you can get it in your vertebral arteries, your visceral arteries, and your external iliac artery, which is the main blood supply to your lower limb. FMD patients stereotypically and more commonly have renal involvement at about 80%. 75% of patients can have extracranial artery involvement, so the blood vessels going to your brain, like your carotid vessels or your vertebral vessels in the back of your brain. 2/3 of patients will have involvement in more than one arterial bed. How does FMD present itself? So FMD, the disease manifestations results from how the FMD is affecting the vessel. So it can lead to ischemia as a result of the tightness or the narrowing that we previously mentioned in terms of stenosis. You can get a dissection or an occlusion or a blockage of a major artery, which will manifest itself as a stroke if it's affecting the blood vessels to the brain, or a heart attack, or what we call myocardial infarction, if it's affecting the coronary arteries. You can have a rupture of an aneurysm or that ballooning out of the vessel. You can also get embolization of a clot that's formed at an area of abnormality, and that parts of that clot, or what we call thrombi, can then move towards smaller caliber vessels and cause a blockage. So there are various different types of signs and symptoms of FMD, and these are based on large registry data in terms of how frequently it is to get some of these presenting signs and symptoms. In general, males tend to have are more likely to have a renal manifestation of FMD, such as flank pain or hypertension, and women are more likely to have some cerebral manifestations of FMD, such as the headaches or the pulsatile tinnitus. These are the most frequent presenting signs and symptoms that we see in clinical practice. So hypertension, particularly if you have a narrowing of a renal artery, headache if you have one of the manifestations of your cerebral vessels, pulsatile tinnitus and dizziness is again is associated with cervical manifestations of FMD or the vessels going to your brain. Cervical bruit is a sign that we find on clinical examination when we put a stethoscope to the patient's neck and we hear the turbulent flow that's caused by a narrowing in one of the blood vessels. Patients can also manifest with flank or abdominal pain, aneurysms, or cervical artery dissections. So about 0.4% of patients with hypertension will be found to have FMD. This is more, the percentage increases in young children. 10% of whom will have FMD or another vascular abnormality such as middle aortic syndrome, which is a narrowing of your thoracic or your abdominal aorta. If we look at large trials that have been done for other reasons, so looking at kidney donors or looking at the CORAL trial, was this trial looking at the benefit of renal artery stenting in someone who has a tight renal artery for atherosclerotic disease. The incidence goes up to about 6% of all patients enrolled in those trials. And again, depending on what cohort of patients you're looking at and what the imaging used to look at those patients, your prevalence can go up to anything to about 1/3 of patients. The average age of diagnosis is 47. And again, this is based on registry data. How do we diagnose FMD? So typically it's diagnosed based on radiological findings. So there are a few different options in terms of radiology that we can use to diagnose FMD. There's a CT angiogram, an MRI angiogram, duplex ultrasound, or catheter angiography. So duplex ultrasound is not commonly used in the UK. It's more commonly used in the US, where they have a higher rate of patients and more expertise based on duplex ultrasound. So you need to have quite a big cohort of patients and significant expertise with duplex ultrasound. A CTA or an MRA is more commonly used here in the UK. A CTA is preferred because of the spatial resolution that you see with the CT angiogram, and also it helps discriminate from other types of vascular manifestations, particularly in the renal artery, where the narrowing can be as a result of atherosclerotic disease, so the disease that we typically see in older individuals with lots of vascular risk factors like high cholesterol, high blood pressure. So a CTA is preferred, but if a CTA is contraindicated for any reason, then an MRA is a suitable alternative. A catheter angiogram is a more invasive test whereby we are inserting a guide wire into the vessel and doing x-rays to have a proper look at the dye as it goes through that vessel. The benefit of a catheter angiogram is that as well as being diagnostic, you can also do an intervention during the catheter angiogram if you have a very severely diseased vessel as a result of your FMD. So typically a catheter angiogram is for patients who have a negative or some ambiguity on a CTA or an MRA, but you still have a very high clinical index of suspicion for FMD. And here on the right, you see some of the angiogram images that we see to diagnose FMD. And again, what you're seeing in these various different angiograms are areas of narrowing or tortuosity, so those bends and twists that we see to try and diagnose FMD. So finally, how is FMD managed? So the important thing to say is that FMD is not managed by one particular specialty. It is a multidisciplinary approach. So there are various different specialties involved in the care and the management of patients with FMD. So myself and Tina are nephrologists, but we also work along with our cardiology specialists, or hypertension specialists, neurology specialists, radiology, who are invaluable in terms of diagnosing this condition, stroke physicians, and vascular surgery. So how do we manage it? So thankfully, we now have the first international consensus on the diagnosis and management of FMD, so that we are all managing FMD in the same manner. And this allows us to characterize patients and to screen them effectively, so that the treatment doesn't differ whether you're here in Manchester or anywhere else in Europe or in the US. So management depends on 4 different approaches. The first is, where is the disease? Secondly is, how badly does it affect the vessel? Thirdly, what are the consequences of the FMD? So what are the manifestations that the patient has or is experiencing? And finally, risk reduction in terms of reducing the long-term risks for patients. So first of all, where is the disease? So it's important to note whether the symptoms are related to FMD or not. So for instance, if someone reports pulsatile tinnitus, then it's important to look at the cerebral vessels in detail and ensure that they have no cerebral manifestations of the FMD. If they don't, and they're still complaining of symptoms relating to a certain arterial bed, that may mean that you need further investigations or referral to a different specialty. So it's really important to do head to pelvic imaging with either a CT or an MRA, again, to see where the disease is there arterial manifestations elsewhere, and also to try and manage some of the patient's symptoms. Here on the right, you see a head-to-toe angiogram looking at both the cerebral vessels, the chest vessels, the pelvic vessels, and the vessels going into your legs. Secondly, is how badly does it affect the vessel? So if you have a focal narrowing or tightness or stenosis of the vessel, this can cause downstream effects, causing a lack of blood supply to whatever organ that vessel is supplying. So here on the right, you see a CT angiogram of, again, the renal arteries. So in image A, you see a very tight stenosis or narrowing of the renal artery that's impairing blood supply to the rest of the kidneys. What we do in this situation is what we call balloon angioplasty, which means that we go in with a catheter insert a guide wire past the narrowing and inflate a balloon to try and expand that narrowing so that we get better blood supply to the organ distal to the stenosis. So in image B, you see that this is someone who is just after having a balloon angioplasty. So that narrowing has been overcome by the balloon, and now there's better blood supply to the kidney. One of the stereotypical manifestations of having a narrowing in your renal artery is having quite high blood pressure. And we know that in patients with renal FMD, if there is a tight stenosis and we balloon that up, that there is a very high cure rate for hypertension or their blood pressure, so that they can come off as medications if they are someone who's on several medications to try and control their hypertension. In very complex and severe cases, we might do surgery to try and overcome some of these manifestations in the artery. This is typically reserved for people with very complex disease who are not amenable to balloon angioplasty. Thirdly, we look at the consequences of FMD. So hypertension is one of the common manifestations of renal FMD or having FMD affecting the renal artery. We don't know exactly what the ideal blood pressure is for someone with FMD, but we treat according to the American College of Cardiology guidelines in terms of hypertension, and we use ACE inhibitors or ARBs. So these are agents such as ramipril, prindopril, irbesartan, or valsartan. And we go by the guidelines to try and get patients' blood pressure under control. Then cerebral manifestations such as headaches and pulsatile tinnitus, most of these are based on symptom control. You can use some medications that you would stereotypically use for migraines. There are some migraine medications that you would try and avoid in patients with FMD. So medications that cause vasoconstriction or tightening of the vessel that may be commonly used in migraines, which would be recommended to be avoided in patients with cerebral manifestations of FMD. With someone with tinnitus, it can be very distressing. So there are various different therapies that we can refer to for patients with pulsatile tinnitus. You may also consider referring them to audiology or ENT specialists or ear, nose, and throat specialists to do hearing assessments to ensure that their hearing is normal. If the patient has presented with an arterial dissection or an aneurysm, so a dissection is a tear on the vessel wall, or an aneurysm where the vessel has ballooned out and unfortunately ruptured, causing a bleed, you treat these patients as you would any other patient who presents with an arterial dissection or an aneurysm. So in the case of a stroke, these patients will be treated with thrombolysis, where you try and break down the clot that's causing the problem, or thrombectomy, where you go and try and retrieve the clot that's causing the problem. In the setting of aneurysms, depending on their size and their location, these will be coiled or clipped to prevent them from rupturing. In terms of risk reduction then, so there's no large trial looking at the use of aspirin specifically in the setting of FMD. But we know that patients can manifest with thrombi or thromboembolic events similar to other vascular abnormalities. So it's reasonable to use aspirin in patients who are both symptomatic and asymptomatic from FMD. However, this is individualized. That means that it is based on the patient's presentation and their own individual risk and benefit in terms of an antiplatelet agent. We know from large registry data that those who smoke have a higher incidence of vascular aneurysms and more adverse events from vascular events, and a higher rate of needing vascular procedures, like what I mentioned earlier in terms of angioplasty and surgery. So we recommend to anyone to stop smoking. We recommend an annual follow-up. So this would include a clinical assessment with whomever specialist is managing your disease. We recommend an assessment of your kidney function if you have a renal manifestation of FMD. And again, depending on where you are in your disease, whether you're at the start, we would recommend head-to-toe imaging, or if you have a certain vascular manifestation that requires annular or serial imaging, we would also recommend that. In general, we tell our patients to avoid fluoroquinones due to the risk associated with dissections or tears in the vessel and aneurysm, that ballooning of the vessel. It's really important to educate patients on red flag symptoms, and these are typically symptoms that involve cerebral manifestations. So any change in your neurological status, such as change in your visual acuity or symptoms consistent with a TIA, or commonly referred to as a mini stroke, we would recommend that you seek urgent medical attention. And pregnancy. So there are some implications for pregnancy. We know from registry data as well that patients with FMD have a higher rate of pregnancy-related complications. This is mainly if you have a renal manifestation of FMD. So patients with FMD who become pregnant have a higher rate of pregnancy-associated complications, such as blood pressure in pregnancy, preterm birth, and also preeclampsia. However, this comes from a paper whereby 96% of the patients did not actually know that they had renal FMD prior to their pregnancy. So it's important to take that into consideration, because if your FMD is managed before your pregnancy, there's no reason to think that you would not have a successful and a good outcome from your pregnancy. So finally, we'll just discuss briefly about what's new in FMD. So here in Salford, we have the FMD clinic, which has an associated MDT with it. So we have input from renal, neurology, radiology, and interventional radiology. And although it's in its infancy, we have over 80 patients who have gone through the clinic with either FMD, FMD and SCAD, SCAD alone, or a mimic of FMD. So these are patients who will have a radiological abnormality that is suspicious for FMD, but on closer examination by our FMD team and discussion at the radiology MDT, they're deemed to have an alternative diagnosis. We also have the UK FMD study, which Tina will update us on later. We also have the European registry data, and we have the first international consensus guidelines in terms of the management and treatment of FMD. This helps us characterize patients with FMD, provide appropriate screening and management, and it ensures that we have improvement in outcomes of all patients with FMD. This only comes from collaboration from healthcare individuals interested in FMD, but most importantly, patients who are willing to give their time and to enroll in these large registry databases. We know from registry data in SCAD, for instance, that FMD is found to be closely related, and patients with SCAD, 45% of patients with SCAD will be found to have an FMD manifestation in one or more arterial beds. Bex has already referred to this in her opening, but this is really important in terms of how we manage our patients, how we screen our patients, and also this particular registry database, which included 373 patients, allowed us to find a link with a particular genetic variant, which will again help us going forward in terms of further management of these patients, but also to try and find a definitive genetic link. So this particular genetic variant, the COL5A1, is a genetic variant seen in Ehlers-Danlos, which is a connective tissue abnormality, which has similar vascular manifestations to FMD. So this variant has become a recurrent variant seen in patients with multifocal FMD, so that kind of string of bead appearance, and has also been shown to have a link with arterial dissections in patients with vascular abnormalities, but also with multifocal FMD. So this, again, is going to help us in the future in terms of screening our patients and trying to identify the patients who are high risk of these more severe manifestations of FMD. So in conclusion, we know that FMD is a rare condition, but there is increasing awareness of the condition. And certainly Tina will testify to this in terms of her referral rate to the clinic. It can manifest in any vascular bed, which is why the head-to-toe imaging is really important to look for manifestations elsewhere. We now have an international consensus guidelines in terms of how we treat and manage patients with FMD, which should help to improve outcomes, not just here in the UK, but globally. And really, all of these advances in our knowledge of FMD only comes from collaboration from various different centres across the world, but also most importantly, collaborations with those who are affected by the condition. So patients actively enrolling in registries, giving us their time and their expertise in terms of how the disease affects them. And that's everything from me. Gurumhagav is the Irish for thank you. So thank you very much for giving me your time.